Good morning, everyone. My topic for presentation is effect of treatment on choroidal vascularity index in active thyroid eye disease patient. Coming to introduction. So thyroid eye disease is an autoimmune disorder which is characterized by inflammation and cellular infiltrate into the orbital tissues, resulting in increase in orbital volume and subsequently the intraorbital pressure. It follows a biphasic course comprising an active phase lasting for 6 to 18 months, followed by an active phase. Commonest method of assessing the disease activity and deciding the treatment approach care is by CAS and Visa score. Besides extraocular muscle involvement and soft tissue involvement, studies have shown that retinal and choroidal thickness are affected in thyroid eye disease. First proposed by Agarwal et al., choroidal vascularity index is a novel and a non-invasive marker. It is obtained by binarization of OCT images and is defined as the proportion of luminal area to total cross-section area. There are dearth of ocular studies showing the effect of thyroid eye disease on choroidal vascularity index. So this is the first study to be done with the following aim: to study the effect of treatment on choroidal vascularity index in active thyroid eye disease patient. Coming to material and method, it is a prospective observational study done from April 2022 to February 2024. We took 38 eyes of 19 patients who had active thyroid eye disease. This was the inclusion criteria and exclusion criteria. All subjects underwent a complete ophthalmological examination and the following data was collected. 12 radial B scan was collected using SSOCT centered on the fovea. Then all the images were uploaded to software, COIN, that is Collaborative Ocular Imaging Network. This is the interface of the software, and it calculated all the parameters with the automated protocol. So coming to results, the study included 38 eyes of 19 patients having active thyroid eye disease. Age of the patient ranged from 28 to 75 years. 57% of the patients were male and 78% of the patient had hyperthyroidism. Coming to CVI, it showed decrease after treatment and it was statistically significant. Choroidal thickness was also decreased after treatment, but that was not statistically significant. There was increase in stromal density index and it was statistically significant. If we look at mean total choroidal area, stromal area, it all showed increase after treatment, but it was not statistically significant. There was decrease in the mean luminal area, and it was also not statistically significant. If we look at visual acuity, ocular proptosis, clinical activity score, movement restriction, all showed improvement and after the treatment, and it was statistically significant. Coming to discussion, the most common parameter of choroidal imaging studied is the choroidal thickness. Agarwal et al. Recently reported a novel quantitative choroidal imaging parameter, choroidal vascularity index, whereas choroidal thickness is affected by multiple factors like age, axial length, IOP, luminal area. CVI is relatively resistant to the effect of these factors and is consistent throughout the day. There are a handful of studies that have shown the effect of TED on CVI. There are discrepancies in the literature regarding the level of CVI in a healthy subject, active and inactive TED. Ludis et al. Found significant increase in CVI in active TED. We have also found a similar decrease in CVI with the activity of the disease. However, Murali et al. And Yetervi et al. Had showed no effect on CVI in active TED. On the other hand, Pehlivanoglu et al. Found increase in active CVI in inactive TED too. The current literature suggests that the choroid of the patient thickens in the active phases of inflammatory or autoimmune disease, including the thyroid eye disease. Choroidal thickness in our study decreased after treatment, inferring choroidal thickness to be positively correlated with clinical activity score. However, there are studies that have shown the contrary result. Recently, Murali et al. Has did not found any correlation in the same. A study by Aksoy et al. In which they evaluated choroidal thickness and choroidal vascularity index. According to their finding, there was no considerable difference in choroidal thickness. However, mean CVI was significantly higher in the Graves' disease group. Similarly, in our study, there was a decrease in choroidal thickness before and after treatment, but that was not statistically significant. But there was decrease in CVI after treatment, and it was statistically significant. The factors that make our results more reliable than the previous studies is the use of swept source OCT rather than spectral domain OCT, and we took 12 scans covering all the quadrants of fovea. However, small sample size, bias in marking the region of interest in software, and no blinding was the main limitations. Coming to conclusion, with treatment, CVI reduces in active TED patient. CVI is a parameter that could be used both for the follow-up and the diagnosis of TED, and this study helps us to understand the choroidal angioarchitecture in TED patients. That's all from my side. Thanks.
Thank you, Dr. Farina.
Thank you, sir.
Any questions for her? You are saying that after treatment, CVI index is reduced, but there may be other confounding factors also. Have you taken care of that one? Matlab, how you have ruled out other confounding factors like age, etc. to discuss it?
Ma'am, we have seen the correlation between the age and CVI, and it has not affected the CVI values.
Have you done it statistically, or you
Statistically, we have
what
done
software you used and what test you used?
Multivariate correlation was done.
Okay.
Thank you, Dr. Farina.
Thank you, sir. Thank you, sir.
Is Dr. Deepak Mishra here? Dr. Deepak? Okay, if Dr. Deepak is not there, is Dr. Priyanka there? Priyanka, yeah. So Dr. Priyanka are present on invaded orbital boundaries.
Good morning, one and all. I would be presenting on invaded orbital boundaries, thinking beyond the orbit. So, the strategic location of the orbit being surrounded by the cranial cavity and the paranasal sinuses predisposes to its invasion from the lesions in these areas. Although the ophthalmic presentations occur late, but these might be the primary reasons why the patient presents to the hospital because of the functional losses, that is diminution of vision, proptosis. Data on these unusual cases of over a decade is collected and compiled. 376 cases were seen from 2010 to 2022 in the Tertiary Care Oculoplastic Center and the Ophthalmology OPD in the Department of KGM. The results were, out of 376 cases, most common were sinonasal tumors, followed by the epithelial tumors and soft tissue tumors. The median age of presentation was around 50 years. In males, most common tumors were epithelial tumors, whereas in females, sinonasal tumors were more common. Proptosis was the most common presentation, followed by decreased visual acuity, pain, and facial swellings. Patients were treated on the basis of disease-specific chemotherapy and radiotherapy, and surgical approaches included transcranial and sinonasal approaches depending upon the origin of the lesion. Post-treatment, the resolution of proptosis was most common, followed by visual acuity, headache, visual field, and ocular motility. To summarize, the most common presentation was proptosis. Paresthesia was most commonly missed. Paranasal sinuses lesions were most frequent. Middle age was most commonly affected, and the treatment approaches include multi-speciality treatment. To conclude, I would like to say that orbital signs are delayed presentations of extraorbital lesions, and these need a high index of suspicion. Thank you.
Thank you, Dr. Priyanka. Do you have any questions?
Yeah. Dr. Priyanka, you are saying that orbital signs are delayed, but have you noticed any cases that first presented to ophthalmologist, then you have to refer?
Ma'am, that is why I had presented this. Although the orbital signs are delayed, but these are the primary causes, due to proptosis, disease, decreased visual acuity, diplopia. These are the primary reasons why patient presents to the hospital, to the ophthalmology department, and when we properly do detailed ophthalmological evaluation and the scannings, we realize that these are not primary origin of orbit, and these are para-orbital origin lesions, and that's when we refer, and a multimodality treatment was performed.
What is your workup protocol?
Yes, ma'am.
How you start and finish the workup?
Ma'am, for any patient presenting to us, we start with visual acuity, pupillary reaction, then we start with orbital margin, seeing the proptosis, then followed by anterior segment evaluation and fundus evaluation. Then we go for imaging protocol, imaging, X-ray followed by CT scan.
So you don't do MRI?
Ma'am, that is very late because we have patients who are very poor and MRI takes a lot of time, so we start with CT scans and X-ray, and if needed, MRI is done.
Fine.
Thank you.
Just one question. 376 cases you were presented.
Yes.
Were there any inclusion criteria, exclusion criteria? What were the kind of patients you included in your study?
So we included patients who primarily presented to ophthalmology department, and later they turned out to have lesions which were not orbital in origin.
So these were the cases of proptosis who came to your department?
So proptosis, diminution of vision, diplopia.
Diminution of vision?
Yes, a deviation of eye, diminution of vision.
Diminution means even cataract patients don't you?
No, no, sir. Later,
What is the purpose of this study? What is the purpose of this study?
sir, purpose of the study is many a times it happens that patient presents to ophthalmology department having
Presents to
lesion-
ophthalmology department means cataract comes, glaucoma
No, sir.
comes,
No,
retinal
sir.
detachment comes. What do you mean by presenting to the ophthalmology department? That's a very broad
Yes,
statement. I'm sure in your hospital you have ophthalmology department. In that you have cataract, glaucoma, retina, orbit. Do you mean to say presenting to the orbit department in your hospital?
Yes, sir, oculoplastic. per se.
Oculoplastic orbit
Per se.
department. So,
And suspecting lesions which were involving orbit, but their origin was primarily not orbit and involving the cranial cavity and paranasal sinuses. Secondary involvement of orbit.
so the
was
inclusion
used.
criteria was of the patients who presented to the oculoplastic
Oculoplastic
department in your
department.
hospital
Yes, sir.
with you mean to say proptosis,
Proptosis.
not ptosis and DCO, only proptosis cases.
No, no, sir. Proptosis, ptosis, any complaint, but later they turned out to be primary from cranial cavity or paranasal sinus.
Because it's surprising, the most number of patients which you say is sino-nasal
Yes,
origin.
sir.
So usually the number of cases of proptosis presenting with sino-nasal origin
Yes, sir.
is usually not that common in at least in my series. Most of them it's usually thyroid or
Yes,
it's hemangioma or dermoid or something. Sino-nasal involvement causing eccentric proptosis is actually not very common, but in your series that seems to be
Yes,
the
sir.
highest
Yes, sir,
number.
because we have seen multiple esthesioneuroblastoma and lot of squamous cell carcinomas, aggressive tumors, which presented to our department in oculoplastic clinic first. Later we referred them to.
Oh, thank you very much. So next is Dr. Karishma Kumar there. Kashmina Kumar. Akansha Agarwal. So Dr. Akansha is going to present of role of reproductive hormones in dacrocystorhinostomy. Request Dr. Anirban to join us, please. You're the chairman.
Should I start?
You can start.
Okay. Good morning, everyone. Today I am presenting the topic role of reproductive hormone in dacrocystorhinostomy. Coming to the introduction, chronic dacrocystitis is a long-lasting, non-infectious inflammation of the lacrimal sac, more commonly seen in middle-aged or older women. The perimenopausal age is the most common age group. This led to the assumption that whether the change in the reproductive hormone play any role in the occurrence of the disease or not. Babor et al. Found estrogen receptor positivity between the premenopausal and the postmenopausal female group. The study was performed to assess the association of reproductive hormone level before and after DCR surgery and to identify if they have any role in the occurrence of the disease. Coming to the methodology, it is an hospital-based observational study. 100 cases were undergone external dacrocystorhinostomy surgery. In this our study, blood samples were collected in the red vacutainers and was sent for serum follicle stimulating hormone, serum luteinizing hormone, serum progesterone, and serum estrogen in the Department of Biochemistry under CLI technique assay in Advia Century machine over a period of 6 months. The inclusion criteria was more than 30 years of age and less than 75 years of age were included. Both male and female were included and patients who give consent to be a part of study. Exclusion criteria was patient with pre-existing hormone level abnormality and who are already on some kind of hormone therapy. Results, out of 100, females were 62 and males were 38, showing a predominance in female group. Coming to the result with association of DCR with serum estrogen level, what we can see that the mean age in male was 53 and female was 38.5 with a t-value of more than 3.2 in female, which show that after the surgery, the estrogen levels were significantly found to be increased in females. Progesterone was non-significant in this association as well as LH. There was significance in the serum FSH level in female. After the surgery, 2.93 t-value was seen in female. That is, after surgery, FSH value was decreased. Studies show that serum estrogen level have a significant association with DCR value is 3.20 at a p-value of 0.05, and FSH was also found to have significant association. Dacrocystitis is an inflammation of lacrimal sac which usually occur because of nasolacrimal duct obstruction. Chronic dacrocystitis is commonly attributed to the effects of stricture of the nasolacrimal duct arising from chronic inflammation. Bebos et al. Study reveals estrogen receptor positivity in only premenopausal females, but no association with other receptors. After extensive literature research, no publication regarding the effect of reproductive hormone on pathogenesis of decrocystitis or regarding the outcome of external DCR was found. My primary focus of the study is to evaluate the failure rate of DCR in patients with increased estrogen level post-surgery, and that we can suppress estrogen production by conservative management to decrease failure rate in these patients. These are my references and acknowledgement. Thank you.
Thank you, Dr. Akansha. Do you have any questions? I have a lot of questions actually.
Yes, even I have a lot of questions.
Yeah.
So start, please.
So, can we go back to your first slide? If you have, do we have time?
We have also.
The first slide, the patients that you included in the study.
Absolutely.
But you can't go back. Okay. So, how many of your patients were in menopause? What was the total number, and what was the number of patients who were in menopause?
So, in my study, most of the patients were in premenopausal group.
Was there a relationship between your sampling and their menstrual cycle?
Yeah, I was considered the menstrual cycle into association since estrogen level is most commonly overall increase in the follicular phase. But the patients are from the rural area, so that's why they were not giving the proper history. They were saying they were not in the menstrual, they were before the ovulatory phase they were coming to us. And what I seen after I have taken the sample just a day before the surgery and just a day after the surgery. What I have seen is just a day before the surgery, the estrogen level was less than 11.08 picogram per ml, and just after day 1 of the surgery, it was 40 to 50. If we consider the follicular phase also, then there should not be so much of discrimination because of surgery.
Is there a stress response to surgery?
Yeah, estrogen level can increase because of stress, but
Would we conclude that DCR increases estrogen level in women, or is it a response to the surgery itself, or any surgery? I mean, we have a lot of interesting questions on this subject.
No, actually what I want to know is that what is the role of DCR in level of estrogen? Estrogen cannot, DCR surgery cannot change the estrogen level.
yeah, ma'am.
It would have been better if you had seen in normal patients who have estrogen level and the patients who are having chronic decrocystitis. But surgery itself has no role on the level of estrogen. And secondly, why males are included in the study? That also I don't understand.
Ma'am, men sir, overall included the patient who had undergone the DCR surgery. Then after the surgery, I seen that females are most commonly coming with increased estrogen levels. Male, it was normal because they don't.
No. I mean, this is a line of investigation that is worth pursuing. Since you brought out something so interesting.
Actually, Dr. Javed Ali's one paper is issued. It showed the nasal cycle increasing in menstrual when there is female undergone menstrual cycle. Nasal cycle also changes because of increased estrogen level. During the menses, nasal congestions is seen. But I try to exclude this during the criteria so that my estrogen level post surgery does not come out.
Actually, there's a very valid point that the level of the female reproductive hormones could play a role in the etiopathogenesis of LLD obstruction. That is accepted, and it's a very interesting line of investigation, because we know that the number of females presenting with acrocystitis and LLD obstruction are much more higher than males. So we want to know why female preponderance is there, whether the role of menopause, post-menopause, the sudden decrease in estrogen level could cause involutional changes either in the bone or in the mucosa, causing the increased preponderance in females. So that is the line of thinking where a lot of research is going on. But what is the purpose of your study in comparing the level of estrogen before and after DCR? That is 1 week before DCR or 1 week after DCR. Suppose the patient is having a period, obviously the estrogen level will be different before the DCR and after DCR it will be different only. What is the connection between the DCR surgery and estrogen level?
So, what I have seen in 100 cases, 18 cases were of failed DCR surgeries. And the failed DCR ones have a higher level of serum estrogen than compared to the normal DCR, which are fine, doing fine, nothing complication. So, I am saying if we can reduce the estrogen level pre-surgeries, so we can decrease the failure rate in DCR. This is a
That's a very far-fetched thing, because there's no way that the estrogen level is going to play a role. See, your osteum might be small, or the mucosal flap anastomosis might be faulty, and there are 101 reasons why the surgery might fail. So to decrease the estrogen level in a female patient, saying that's going to increase your success rate, is very, very far-fetched. See, most of the studies going on is whether estrogen level has a role to play in the etiopathogenesis of LND obstruction. That's the direction in which the research is progressing. They're not saying the surgery fails because the estrogen level is high. The surgery, there's no way, osteum is so big, and there's no way a change in estrogen level is going to shrink your osteum or cause so much mucosal involvement that the mucosa is going to stick to each other, so that you decrease the estrogen level and keep the osteum patent. That's not the way I think anybody thinks.
Okay.
So anyway, it's a novel way of thinking what you've done, but see, including males in your study, and I think you should have clarity first on what is the purpose of the study, what is the inclusion criteria, and what you're aiming to see. All that you should be very clear. If you say I'm going to measure estrogen levels, then you should not include males, obviously. You can't include the 30-40% of your study male patients and say that the estrogen level didn't fluctuate in males. Obviously it not fluctuate, because the estrogen level is, the male patient is not going to fluctuate. So that you have to be clear.
We were actually wondering if postmenopausal women, if we could do DCR universally, whether we could improve their osteoporosis. I mean, that is what we were drawing from after reading your abstract. So, very interesting conclusions that one can draw from here, but putting two different lines of thought and trying to draw a conclusion between them, where there may not be any biological plausibility, is a difficult way to take science forward. Okay.
So what you can do next is that you can plan a study where you can plan patients with these female patients with this decrosis, without decrosis, and compare them both.
Or you can take pre and postmenopausal women and see whether there's any change. And other surgeries.
Thank you, Dr. Kansha. And is Dr. Sachi Srivatsa there? She's going to present a rare case of sino-orbital cerebral mucormycosis in an immunocompetent infant.
Good morning, my respected judges on the stage and my dear friends. Today I am here to present my paper on a rare case of sino-orbitocerebral mucormycosis in an immunocompetent infant. Sino-orbital cerebral mucormycosis has been very rarely seen in infants, very few case studies describing the same. The disease might mimic orbital cellulitis or tumor, hence it may be difficult to diagnose. We hereby describe the case of a 1-year-old immunocompetent male child suffering from this disease. He underwent exenteration and FES along with systemic antifungal therapy due to extensive involvement of orbit, paranasal sinuses, and cavernous sinus. So the purpose of the study is to discuss the clinical course, treatment, and prognosis of an immunocompetent infant male diagnosed and treated for sino-orbitocerebral mucormycosis. So the method is case report. It's of a single case. A 1-year-old male child presented to IOPD at ESIC Medical College and Hospital, Faridabad, with abaxial proptosis of the right eye since 1 month. The proptosis was associated with chemosis and mild discharge. There was mild corneal exposure and pupils were fixed and dilated. The extraocular movements were very severely restricted in all the cases. The proptosis was also associated with the swelling of the cheek on the right side. The overlying skin appeared tense and there were prominent vessels all over. On palpation, the proptosis was tender, non-reducible, non-compressible, and the mass was firm in consistency. The mass was extending up to the right maxillary region and involved the upper jaw and palate on the right side. The patient had earlier consulted another hospital where his MRI of brain and orbits was done. Also, a biopsy of the mass was taken in the previous hospital. The first MRI was suggestive of well-circumscribed intracorneal mass in the medial right orbit causing anterolateral displacement of the right globe and lateral displacement of the optic nerve, likely neoplastic. Then the biopsy report came, which was suggestive of fungal elements in the samples, indicating or suggestive of mucormycosis. The patient was admitted in the pediatric department of our college, and IV amphotericin B was empirically started. Now we did the immunodeficiency profile of this child. The viral markers were negative and the immunological profile was normal. The viral markers of the patient's parents were also negative, and neither of them were known diabetics or had deranged blood sugar levels. The workup for leukemia and other hematological malignancy was negative, nor did the child have lymphoma or any other malignancy. The patient did not respond to systemic antifungals and IV antibiotics. The patient then underwent FES and endoscopic orbital decompression. However, there was consistent increase in the proptosis despite treatment. Patient was then given retrobulbar amphotericin B injection twice. Initially, the patient responded to the first dose. However, there was no improvement later on. The repeat CECT done at this stage was suggestive of ill-defined, mildly enhancing soft tissue lesion in the right intraconal and extraconal space, which was measuring approximately 33 into 26 into 45 millimeters, displacing the right orbit anteriorly and laterally. The lesion was infiltrating the optic nerve laterally, medially was infiltrating the nasal cavity with rarefactions of the middle orbital wall and anterior wall of the maxillary sinus. Inferiorly, it was extending up to the masticator space, measuring approximately 3.6 into 3.6 centimeters. Superiorly, there was intracranial involvement through the orbital fissure with bulging of the cavernous sinus, measuring approximately 18 into 13 millimeters. Laterally, the lesion was involving the skin. There was also involvement of the right ethmoid and maxillary sinuses. All these findings were suggestive of further worsening despite debridement, retrobulbar amphotericin B injections, and IV antifungals. Hence, total orbital exentation was planned in this child. So this is the image of the child. This is the picture of the child. He's a 1-year-old male infant. And as you can see, there is marked proptosis, swelling and fullness in the temporal region, and also in the right side cheek region. So this is the axial CECT image, which is showing diffuse periorbital, orbital and periorbital and optic nerve infiltration by the mucor with marked proptosis. And this is a histopathological image of the orbital tissue showing branched aseptate hyphae. The result of this study is the total orbital exentation of the child was done in general anesthesia under very high risk consent. The child started improving after exentation. He remained stable till 1 month post surgery, and he was followed up and regular dressings was done in this child, but he was lost to follow up after 1 month. So conclusion is, orbital mucormycosis is rarely reported in immunocompetent infants. High rate of morbidity and mortality makes it necessary to be diagnosed at the earliest and to be treated aggressively. Exentation does help in improving the condition and may be life-saving. However, it increases the morbidity and requires a long course of rehabilitation. Thank you very much for your patient listening.
Thank you, Dr. Sachi. Thank you. Do you have any questions?
How did you make the initial diagnosis, and was any culture done for this fungus?
Yes, sir.
Because mucor.
The diagnosis was histopathological, in
Yeah.
which we could see the branched aseptate hyphae, as I've shown in my picture.
Yeah.
Initially,
so this was at the time of the exentation, or this was a prior biopsy that you did when
prior
you
to
had a
biopsy,
retrobulbar?
from nasal route,
From
the
the nasal
ENT
route.
people did
Yeah.
the biopsy, and from that we made the diagnosis of mucor.
Was it cultured?
Yes, sir.
Was the
Yes, sir. It was
specimen
cultured also.
cultured?
Both
Did it grow?
microbiological and histopathological examination was done.
So did it grow one of the zygomycetes, or it did not grow? Anything on culture?
Sir, culture mein nothing definitive came out.
Nothing definitely came
Yes.
from culture. Okay. The other problem is your child was treated up to 1 month, right?
The child was very malnourished, marasmic.
No, I understand that, but you have a child whose orbit has been exentrated, but there is extension of disease into the cavernous sinus. So you already have CNS involvement.
Yes, sir. We already had CNS
Almost
involvement at the time of exentation. So prognosis was already very poor, and he was given IV amphotericin B for a long time, around 1.5 months, and even after exentation, but then he was discharged on oral fosagomazole, and then we lost him to follow.
What do you think is the cause of
this case? This is not common in immunocompetent people. What is the
Ma'am,
cause
it
of
is very, because in fact, mucormycosis per se is very uncommon in children.
Yes.
Especially in infants, it's very rarely reported. There's a case study in which around 5 infants they have reported by Amanati et al. In BMC Journal of Infectious Diseases. But there was as such no risk factor. He was fine. In fact, his weight was also good when he was prior to his diagnosis. There were as such no signs of malnourishment or any kind of any immunocompromise. But there has been postulations that exposure to hay or fodder in house might be a reason. So since he lived in village, we concluded that it might be a possible source.
Thank you, Dr. Sachi. Let me help you to put in a few more radiological images. The CT which you showed, the sinus actually is clear. The Edmond sinus is completely clear. So it looks like it's completely intraorbital only. We can't see any spread from the
So it
sinus.
was actually post-fest, maybe.
No, the sinus was normal. There's no signs of fest being done. I think it's a pre-op CT. Anyway, thank you so much for your presentation.
Yes.
Thank you. Is Dr. Nilesh Jain there? Dr. Nilesh should be presenting on congenital bilateral upper eyelid eversion, a rare disease.
Good morning, Chairperson and my dear friends. I'm presenting congenital bilateral upper eyelid eversion. It's a very rare disease, and this is the 58th case in the world. I reported this. This is a case report. It's not changing. So, yeah. So I'm Dr. Nilesh Jain. This is a 12-hour-old female newborn referred from another hospital. She's a first baby to 22-year-old woman. Antenatal history was uneventful. She delivered with the cesarean section. And on general examination, she was afebrile with a tachycardia. And on eye examination, both the lids were totally everted. And there is a chemosis with a greenish discharge that is suggestive of infection. And on examination, with the help of Desmet's lead director, we just examined it and found that there is a cornea was clear and fluorescent staining was negative. So, blood investigation was done and shows leukocytosis, along with that increased bilirubin count. So we took the help of neonatologist and we started with the admitted in NICU and started with the IV antibiotic and phototherapy. And for eyes we just tried the manual inversion of the lid, but it was not possible. Then we tried in Maxell dressing also, but that was also not working. So then we tried 5% hypertonic saline dressing, and we changed it every 6 hourly. And along with that, we have started with the lubricating eye drop and broad spectrum antibiotic. And to our surprise, by 6th day, it was totally completely normal. So coming to the discussion part, so it is a very rare disorder. It could be unilateral or bilateral. So Adams in 1896 first described this case as a bilateral ectropion, double ectropion. And Seller et al. In 1996 reviewed the literature and found 51 more cases. And till now 7 more cases has been detected. My case is 58th case in the world. And no pathology has been put forward, but more common seen in Down's baby or collodion skin disease babies and black races. And a few possible mechanisms has been put forward, which is shortening of the anterior lamellae and elongation of the posterior lamellae of the upper eyelid. There is a failure to fusion of the orbital septum with the levator aponeurosis, and there is a laxity of the ligament, lateral canthal ligament. Coming to the goal of management to prevent the desiccation and allow spontaneous eversion of the lid. So conservative management, it includes moist dressing, eyelid tapping, pressure patching, topical antibiotic, lubricants, and topical 5% hypertonic saline, which we used in our case. And surgical options are scarification of the exposed conjunctiva, temporary tarsorrhaphy, subconjunctival injection of hyaluronic acid, fornix sutures, full thickness skin graft to the upper lid, and compression eyelid sutures. Lid manipulation should be avoided in neonates, especially to prevent the respiratory arrest. And complication could be secondary infection, epimerization of the conjunctiva, and some patients corneal perforation is reported. This article is presented in IJO in October 2020. So my take-home message is presentation is really alarming, and it really needs urgent attention to prevent secondary complications. And my case was get cured with the help of medical management. So we emphasize on conservative approach, and awareness among healthcare personnel is really important, especially the neonatologists and pediatricians to see who are seeing it for the first time. Thank you so much.
Thank you, Dr. Nilesh, for the excellent presentation. Do you have any questions for him? Thank you so much. Thank you.
Thank you.
Is Dr. Nidhi Tomar there? Dr. Nidhi B in rhino-orbital mucormycosis.
To all chairpersons, seniors and my colleagues. Today I'm going to present myself, Dr. Neha Modani, second year junior resident from Pune. Title of my topic is retrobulbar injection of liposomal amphotericin B in rhino-orbital mucormycosis, a glimmer of hope. As we all know, black fungus is misnomer used for the mucormycosis. This is the one of the emerging and angioinvasive infection caused by ubiquitous filamentous fungi of order mucorales of zygomycetes. Most common reported case is of the rhino-orbital cerebral mucormycosis. The most common mode of transfer is by the inhalational route. Angioinvasive fungal infection manifests in four forms, that is rhino-orbital cerebral, pulmonary, gastrointestinal and cutaneous. Overall mortality in rhino-orbital cerebral is about 30 to 70%. This pathogenesis behind mucormycosis, that is inhaled spores get trapped into paranasal sinuses where they block the replication of macrophages leading to fungal proliferation. It causes necrosis of the involved tissue, causing involvement of the orbit and cerebral. Most common risk factor we have seen is the diabetes mellitus, followed by the immunocompromised conditions along with the iron overload. Also the irrational use of the corticosteroids, intubation, mechanical ventilation, O2 therapy has shown rise in the cases. Patient present with symptoms like headache, stuffiness of nose, facial pain, diplopia, diminution of vision, along with the clinical features, that is proptosis, lead edema, ptosis, clinical extraocular movement restriction. For these patients, a systemic antifungal, topical antifungal as well as antibiotics are used. Surgical debridement, FES surgery along and or orbital exentration along with treating the underlying predisposing condition like diabetes mellitus. Depending upon the history, clinical signs, symptoms, MRI and CT scan reports, we can go for surgical intervention, that is exentration. After calculating the exentration score, if score is more than 19, we will plan for the surgery. This is the exentration score, which is depend upon signs, symptoms, fundus finding and imaging. Aim is to study the role of retrobulbar injection of liposomal amphotericin B in the patients with mucormycosis, that is rhino-orbital. The objective is to assess the clinical response and the safety of the transcutaneous retrobulbar amphotericin B to assess the outcome of the TRAM for rhino-orbital mucormycosis patient post-COVID as an adjuvant to the standard systemic antifungal therapy. It is a prospective interventional study carried out at tertiary healthcare center over a period of 10 months duration during second wave of COVID. Patient having signs, symptoms, history suggestive of mucormycosis, the patient proven positive for the fungal biopsy were included in this study, and patient negative for fungal biopsy, patient not willing for study or drug allergy were excluded. In the study, 110 patients were admitted. Among this 110 patients, 90 patients is having orbital involvement without cerebral involvement. These 90 patients were the target population for my study. After seeing the diagnosis was confirmed, after seeing clinical signs, symptoms, ophthalmological examination, microscopic examination and routine lab parameters and radiological investigation, fungal culture, the patient was confirmed. These are the histopathological slides showing the invasion of the mucormycosis in the optic nerve. Second image showing the mucormycosis invasion in the artery along with the thrombus formation. Third is the microscopic image showing the broad accepted fungal hyphae consisting of the mucous species. These are the few MRI reports, axial view, orbit plus the brain, showing left eye or orbital mucormycosis, showing mucosal thickening, sinus were involved and the orbital fat strangling was seen. These are few intraoperative pictures of the exentration. Out of 110 patients, 90 patients were showing ocular involvement without cerebral manifestation. This is how the liposomal amphotericin B was prepared, and the retrobulbar injection was given after taking a prior consent and under all aseptic precautions. The doses were 3 to 5 doses depending upon the staging and the severity. It was given daily or alternate day. While this BSL, electrolyte, HB, LFT, KFT was monitored. Supportive management by moxifloxacin was given. Among the demographic profile shows that almost 2/3 patients were male, and the ocular outcome of the RAM was 61%, or almost 2/3% got improved with the retrobulbar amphotericin B. 12.2% cases got deteriorated. We took them for exenteration. These are the few clinical images showing the improvement, how the clinically patient improved after the retrobulbar injection. This is the MRI report showing how the left eye orbital mucormycosis got improved. These are few deteriorated cases. This is age-wise incidence showing that mostly 51 to 60-year male patients were got infected. This is the risk factor bar diagram showing COVID status was more commonly seen, followed by the diabetes mellitus. The result is that among 51% patients showed improvement after 3 doses of retrobulbar amphotericin B. 15 cases showed improvement after 5 doses, while 18 cases neither improved nor deteriorated, and 11 cases got deteriorated even after giving 3 doses. So these patients were exenterated. Hence, conclusion is that mucormycosis is treated with a multi-dispensary approaches. Early suspension, timely diagnosis of mucormycosis at rhinoorbital stage warrant us early salvage of life as well as the visual function. The patients of mucormycosis without cerebral involvement can benefit a liposomal amphotericin B by reducing the spread of disease, conserve vision, control ocular symptoms, and spare the glow. Thank you.
Thank you, Dr. Neha, for the excellent presentation. Do you have any questions for her?
Yes. What was your type of study?
It is one prospective interventional study.
And the ethical clearance were taken for that?
Yes.
Because see, for prospective study, you need a very rigorous ethical clearance.
Yes.
You have not mentioned that one.
What I understand is you had 90 patients who were included in this study. But what I did not understand is why did every patient get transcutaneous amphotericin B? Because the way we plan is if you have localized disease or retroorbital disease, but not diffuse disease, those are the patients who are selected for transcutaneous injection. The others, the ones with diffuse disease, would go for an exentration upfront. So, how many of those your patients were diffuse and how many were localized?
So almost all patients were having orbital involvement.
Yeah, all of them had orbital involvement, otherwise you wouldn't have given the injection. But how many of those patients were diffuse and how many were localized? That would explain why your results show 2/3 patients improving and 1/3 who did not improve.
It was localized.
All of them were localized. But
we
if you can find that data, that would make the study very interesting. Okay.
Thank you, Dr. Neha. Do you have any questions for her? Thank you, Dr. Neha. We'd like to invite Dr. Marian Polly, who will talk to us on functional outcome in patients undergoing orbitotomy for cavernous venous malformation.
Good morning all. My paper is on functional outcome in patients undergoing orbitotomy for orbital cavernous venous malformation. No financial interest. As we know, cavernous hemangioma is a simple venous malformation seen in middle-aged females. Excisional biopsy remains the treatment of choice. However, visual impairment has been reported in 2 to 24% of cases. So in this contest, we did a study to analyze the functional outcome in patients undergoing orbitotomy for intracorneal cavernous venous malformation. It was a retrospective interventional study of 8 years in a tertiary care center in South India. Detailed history, ophthalmic evaluation, orbital imaging, and tumor volume was calculated in all the cases. Surgical approach was determined based on the location. Lateral orbitotomy with or without osteotomy was done using stellarite incision or Burkitt's incision. Cryo-assisted tumor removal was done in all the cases. Muscle disinsertion and reinsertion was done accordingly, and pupil was monitored throughout the surgery. Those with 6 months follow-up were included, and those referred for revision surgery as well as in the extracorneal location were excluded.
Patient was admitted for 1 day and discharged next day and followed up at 1 week, 1 month, 6 months and yearly thereafter. Refraction was done at follow-up visits. Color vision and visual field and OCT was done if there is subnormal vision. The main outcome measures were changes in visual acuity and refractive error, ophthalmoscopic changes and complications related to surgery. We had 10 eyes of 10 patients with a mean age group of 44 years with a mean follow-up of 21.8 months. Females outnumbered males in our study. Proptosis was the most common presenting symptom. Color vision was normal in all patients pre and post-operatively. Visual fields was also normal. One patient had central scotoma. Coming to the ophthalmoscopic findings, hyperemic disc and disc edema was present in 2. Both were resolved in the postoperative final visit. Chororetinal folds were present in 4. It persisted. Serous macular detachment present in 1. It persisted. Visual acuity was less than 6/18 or equal to 6/18 in 1, and it has improved in the postoperative period. All other patients had good vision pre and post-op. Coming to the changes in hypermetropia, hypermetropia was present in 70% of cases with a range of plus 0.5 diopters to 5 diopters, of which 4 eyes had more than or equal to 2 diopters. In the postoperative period, 5 had persistent hypermetropia, and there is an average reduction of 33.6% reduction. Coming to the radiological features, the maximum horizontal dimension ranged from 1.4 to 2.9 millimeters, and the tumor volume ranged from 2.1 to 7.6. Infralateral was the most common location. Lateral orbitotomy alone was done in 7 cases, and lid split was in 1. In 2 patients, we combined both lateral orbitotomy with lid split, and medial rectus was disinserted in 1 patient to facilitate tumor removal. Coming to the complications, tonic pupil was present in 1, and late ophthalmos was present in 1. This is my second case. She was a 45 years hypothyroid, pre-op hypermetropia, intracorneal mass, underwent disc edema, complete excision, follow-up at 1 month. So coming to discussion, this is a unique study of 10 patients where dual approach has been used in 2 cases and none of them had any loss of vision. Coming to the visual impairment following excision of cavernous hemangiomas, there is a reduction in best corrected visual acuity reported in 3 to 32% of cases, and no light perception has been reported in 1.2 to 4.2% of cases. Can occur due to posterior optic nerve ischemia or CRA or due to traction or manipulation of orbital tissues. However, in our series, all had good preoperative and post-op vision. Dual approach we have used in at-risk patients, and muscle was disinserted. We had 33.6% reduction in hypermetropia. As per Harris et al., he noticed 75% of preoperative hypermetropia was retained in spite of complete tumor removal. Scleral fibrosis and remodeling with a chronic distortion can lead to permanent scleral deformation and permanent change in axial length. Coronal folds was present in 40% of cases, and all the folds, even though reduced in height but persisted even after complete tumor removal. The reported incidence is 14% to 41%. In our series, only intracorneal masses we have taken, and the long-standing coronal folds can lead to RP hypertrophy and atrophy. One had tonic pupil. It occurs due to injury to short ciliary nerve or ciliary ganglion. It's a small sample size limitation. So what this study adds is a functional outcome following orbitotomy for intracorneal cavernous venous malformation remains excellent with careful surgical technique, proper selection of surgical procedure, and careful intraoperative dissection. 2 surgical approaches can be combined in at-risk tumors. Post-op recovery depends on the preoperative findings. Smaller tumors, small refractive errors, favorable parameters. Long-standing larger tumors with globe indentation can lead to persistent choroidal folds. So we propose early surgical intervention in symptomatic intracorneal cavernous venous malformation, and persistence of choroidal folds in the postoperative field needs further research. These are my references. Thank you.
Thank you, Dr. Marian, for the excellent presentation. Do you have any questions for her?
Is there any role of intervention in radiology in these cases?
Yeah, we can if you are suspecting one intracorneal other arterial malformations. But here, all patients preoperatively itself, the diagnosis was quite evident.
Marian, can you tell us a little more about that patient where you combined lateral orbitotomy with a lid split? So where was the tumor? And
it was deep apical and intracorneal, apical intracorneal. So when I was removing the tumor, that pupil was dilating. So I was literally scared whether the patient will get central retinal artery occlusion because of the pressure. So I just split the lid so that the tumor removal was easy, so that for the safety.
Have you done an analysis of the radiological appearance of the tumor before surgery? Because like you know, there are two types of tumors, the
Yeah,
pear-shaped
pear-shaped,
hemangiomas and the circular ones.
Yeah.
The circular ones usually have excellent prognosis. It's only the pear-shaped hemangiomas which go right to the apex, no, which are very dangerous.
Yeah.
Have you, in your study, has any patient
I
presented
had
with
two
the-
cases.
with the-
For both, I had did the dual approach. While I was removing the tumor, the pupil started dilating. So I was literally
dual approach of lateral orbitotomy with lid
lid
split, is
split.
it?
So when the moment I split the lid, the orbit was completely open. Otherwise, when I do the traction on the lateral wall, the lid is getting stretched and pressing on the globe. Tumor is also pressing on the globe. So I don't want any
saw in your
CRA.
conclusion, you had concluded that early surgery is indicated for symptomatic. What do you mean by symptomatic? What will be the
Proptosis, then with hypermetropia and disc edema. I mean, what are the signs? Usually patient presents asymptomatic. We can find out proptosis, do imaging. So when the vision is normal, feels normal, pupil normal, sometimes when we tell the patient you can wait for either 6 months or 10 months or you come for yearly follow-up with MRI. In that case, I think we can intervene early.
So a patient with mild proptosis with excellent vision and no symptoms at all.
If the patient is willing, I will advise.
It's an indication for us to counsel the patient for early
Surgery. Because I had one patient where the serous macular detachment persisted. He was keeping the tumor for at least 5 years. So everybody was telling the same. If you remove the tumor, your vision will go. But then I told, I also actually assured the patient your vision will improve after the surgery. But his vision pre-operate, it was 6/18, improved to 6/12 in the post-op. The serous macular detachment and choroidal folds was persisting. He had a very large tumor. He was the biggest biggest one in my series.
Because usually the choroidal folds usually does not have significant visual impairment
Immediately
usually.
no, but long standing they can have RP atrophy and all.
Thank you, ma'am.
Yeah.
Thank you. We'd like to invite Dr. Ashwini Raut. Is Dr. Ashwini there? She's going to speak on double stage flap procedure for eyelid reconstruction in a case of meibomian gland carcinoma.
Good morning, everybody. To all the judges and my colleagues sitting here. I'll be talking about double-stage flap procedures for eyelid reconstruction in a case of a meibomian gland carcinoma. I would like to thank Dr. Saptagiri sir for giving me this case. So, meibomian gland carcinoma has a propensity to mimic multiple eyelid conditions like chalazion, basal cell carcinoma, squamous cell carcinoma. Aggressive diagnosis and multimodal surgical treatment helps to tackle this condition and give patient a good cosmetic as well as a functional outcome. So reconstruction challenges. So in our case, it was an upper lid meibomian gland carcinoma, and for upper lid, it plays an important role in maintaining the ocular surface as well as it gives a structural rigidity and stability to the eyelid. So if the size of the defect is less than 1/3, it can be closed directly if the lid laxity allows. But when they are bigger than 50%, flaps and grafts will be needed for reconstruction. So in a present case scenario, we did something called as a modification of a Cutler-Beer technique. So what is a Cutler-Beer technique? A Cutler-Beer technique is used for an upper eyelid defect in which we use only the myocutaneous flap from the lower eyelid is transposed to the upper eyelid. But in modification of Cutler-Beer technique, which I will be telling in my case, so our case was a 58-year lady with a right eye upper lid swelling since past 3 months, which was gradually increasing in size, was associated with pain and bleeding, especially when she rubbed her eyes, and the visual acuity in her right eye was 6/36, whereas the visual acuity in her left eye was PL positive as she had pseudophakic bullous keratopathy changes. So this is the presentation. There was a full thickness lesion extending from the medial canthus to the lateral canthus with lid margin involvement, loss of hair follicles, and mild lag of ophthalmos was there. Management, what we did was that initially we did an upper lid full mass excision and the specimen was sent for histopathological evaluation. Histopathological evaluation showed an intraepithelial and focally invasive meibomian gland carcinoma. Following which we did a reconstruction of the defect with the help of an forehead Frick's flap. The anterior lamella was reconstructed and for posterior lamella we used the donor sclera. So this is 1 month post-operatively, the patient presented to us the cilia of the forehead flap had overgrown and they were rubbing the cornea, leading to corneal exposure changes. And as this was the only seeing eye, as you can see in this case, there is a lateral pedicle graft and corneal exposure changes. So as this was the only seeing eye, we had to do a lid sharing procedure. That is, we did a modification of Cutler-Beer technique. As we know, in a Cutler-Beer technique, only the myocutaneous flap is used, but in this case, we used the tarsoconjunctival flap of the lower eyelid. So what we did is that we took an incision in the lower, first we took a lid margin incision in the upper eyelid, and then we split the anterior and the posterior lamella. In lower eyelid, 2 millimeter below the lid margin. In ideal Cutler beard, it is taken 4 millimeter, but in our case, we took it 2 millimeter below the lid margin. We separated the anterior lamella and we separated the posterior lamella. The tarsus and the conjunctiva of the lower lid was opposed to the tarsus and the scleral graft and the that is the posterior lamella of the upper lid with the help of a 6-0 vicryl suture, and similarly the anterior lamella were also sutured. So this was the patient achieved there was a closure for at least 6 weeks. We didn't do the flap division procedure, and after 6 weeks when we called the patient, we did a flap division procedure, and the patient achieved an adequate lid contour and there was no lag of thalamus. So the discussion is that the modified Cutler-Beer technique. So why we didn't go initially with the Cutler-Beer technique? Because the patient had only seeing eye. So we wanted to prevent a flap procedure, as it will cover the eye of the patient and will obstruct the vision. But that's why we initially did a forehead Frick's flap. Then as the cornea of the only seeing eye was getting compromised, we did a modified Cutler-Beer technique in which we used an anterior lamella, which was reconstructed by using a lower lid skin and a pedicle flap, and the forehead and the posterior lamella was with the help of the lower lid transoconjunctival flap. So this technique of modification of the Cutler-Beer, it gives rigidity to the upper eyelid, and thus not only helps to maintain the structural support, but also helps to give a better functional as well as a cosmetic outcome. So it allows for a complete reconstruction of the upper eyelid defect with required rigidity and support. I would like to thank everybody for this.
Thank you, Dr. Ashwini. I just have one question. Did you do a frozen section when you did the first excision? How did you determine marginal clearance?
So initially we did a 2 by 20 millimeter excision of the mask, and then we gave it for a histopathological evaluation, and it showed that the margins were infiltrated. After that, a wide excision of this, again the patient underwent a wide excision procedure in which almost like 80 to 90% of the lid was excised. Beyond the pre-existing defect. So almost like 35 millimeter of excision was done, and that specimen was sent for histopathological evaluation, and then it showed margin clearance, and after that we did a forehead pedicle flap.
Did you do any conjunctival map biopsy? Considering the extensive involvement of the complete eyelid, did you do a map biopsy of the conjunctiva to check if there's any, because you know maybe customers can have skip lesions and everything. Was a map biopsy?
No, sir, we didn't.
No map biopsy was done. Because almost the whole lid is involved.
Lid is involved, yes. We didn't.
So when did you do the second sitting of excision of the?
So immediately after we got the specimen.
4-5 days? Or
1 week later, sir.
So for 1 week, patient had no upper lid. It was completely exposed.
Yes, sir. Like, for 1 week we had called her back, as this is like camp patients. She came back.
How did you protect the eye 1 week without an upper lid?
So we gave lubricating eye drops, and we told her to come back immediately after 2 to 3 days. But the patient, she came little bit later. So following that, when we got the histopathological report, we immediately took her for the remaining margin clearance.
Another thing, the modification, usually we advise not to make any incisions very close to the lid margin, especially in the lower lid. Number one, you can get ischemia. Number two, you can have loss of hair follicles. All the hair follicles will go. So that's why you make it a little bit lower,
yes,
so that for a standard Cutler beard,
yes,
so that you have vascularized pedicle, which will take up well. Make it very close to the lid margin. You can have a lid margin necrosis in the lower lid. Hair follicles, of course, will all go.
Correct me if I'm wrong. My understanding of the Cutler beard procedure is a condition where you have a composite flap which is derived from the lower lid, which includes both the anterior and the posterior lamella. So where is this modification that you're talking about?
So in Cutler-Beer technique, we use only the myocutaneous flap of the lower
I
lid.
mean, that is not the way most of us understand the Cutler-Beer procedure, right? It's a composite flap, both posterior and interlamellar.
One more thing, how many surgeries the patient has undergone?
Ma'am, 3 procedures.
If you
Fourth
had
one was the flap division.
calculated the measurement of the frontal flap, it could have been done in a laser surgical procedure, don't you think so? But see, once you have done the foreherectomy, this could have done with a Cutler-Beer itself instead of doing the frontal flap.
Ma'am, the patient only had, it was a only seeing eye.
Right.
So we didn't do the flap
And you left
procedure.
it unprotected for 1 week.
No, sir, yeah.
So interesting choice
1
of
week complete null upper lid, the chance of corneal exposure is far greater. Actually, to do a Cutler-Beer flap is cornea would have been safer actually.
Yes, sir, but...
Anyway, it's a novel experiment. Congratulations. Thank you so much for your excellent presentation.
Thank
Thank
you,
you. Now, we'd like to invite Dr. Shefali Chahar to speak to us on transconjunctival intralevator triamcinolone injection for upper eyelid retraction and thyroid eye disease.
Good morning, everyone. Thank you so much to the scientific committee for this opportunity to present my last year's paper as a keynote in this session. So it's titled as Transconjunctival Intralevator Triamcinolone for Upper Lid Retraction and Thyroid Eye Disease. Thyroid disease, as we know, is an enigma. The most common disease that affects the orbit. It is complex. It is poorly understood still, and it has an autoimmune pathology is what we know. Because of the autoimmune pathology, there's growth in the orbital fibroblasts, which can lead to multiple complications in these cases, naming lid retraction, myopathy, proptosis, and optic nerve dysfunction. The natural course of the disease is also what we are aware of. It has a dynamic phase, which is the active phase, and a static phase, which is the inactive phase of the disease, which is popularly called as the Rundle's curve. And the most common eyelid symptom that we come across here is eyelid retraction, which is seen in almost 90% of the cases. And the mechanisms that have been explained for this retraction is probably the overaction of the levator and the molars because of the increase in sympathetic tone, fixation duress, levator hypertrophy, or the muscle contractions or fibrosis, and abnormal adhesions between the levator and the surrounding structures, scarring or inflammation of the septum and the anterior lamella. So what are the challenges that we face in these cases? One is the functional challenge, that is the lag of thalamus and the exposure keratopathy that ensues, and the cosmetic challenge, of course, because of the psychosocial impact that this retraction can have on these patients. And what are the management options in hand for us? They are either surgical or non-surgical. Surgical options, we are very well aware in thyroid eye disease, we cannot touch when it is in the active stage. So in active stage, we have to wait for that stage when the fibrosis has set in, and then only we can go ahead with the surgeries. And the non-surgical options I have also listed here, like botulinum or hyaluronic acid gels or triamcinolone injection. So when we look at the levator recession papers that have been published, the mere list of the papers can actually tell us that there's no standard protocol that exists for these retractions, and no standard protocol treatment has been devised. And even with our experience, we know that patients are not very happy with the contour and the lid margin that they, lid crease that they get. And the non-surgical options have also been studied, like Botox or hyaluronic acid, and comparison studies in between them. So these are the questions that we actually think when we think about these management options. And keeping those questions in mind, we try to evaluate the role of transconjunctival intralevator injection in the upper eyelid for these cases. 37 eyes of 22 patients was involved, and it was a retrospective interventional case series, and wherein we gave the injection in subconjunctivally in the OPD setup according to the dose that we required, and this is the analysis that we got. The mean age was 46, females were predominant, and bilaterality was seen in 13 of our cases. Mix of hypothyroid and euthyroid cases were present. Interestingly, we had more inactive TED cases in our series, that was 16. So 2 index cases, this is an active thyroid, which is, she was an IVMP, and after her 3 cycles, we decided to give, we do all the measurements when these patients come at every visit, and we note them down. And while her IVMP doses are going on, after the 3 cycles, we give her 1 injection of upper lid triamcinolone acetonide, and this is how she basically, this was the result that we got after 1 injection for her. And this is the measurement that we did after the injection. This is a second index case, which is a case of inactive disease. And again, we did all the measurements in this case, and he had to receive 2 injections, but he also gave a gratifying result. These are the measurements after his second injection when it settled down. So the mean number of injections that we got was a range of 1 to 4. The mean average dose was almost 23 milligrams, and time to maximum response was 37 weeks. And all the measurements that we did, MRD1, PFH, superior scleral show, and the lag of thalamus showed a statistically significant response in our case. And there was no regression from the maximal response, and only one patient had a transient increase in intraocular pressure, although it's a subconjunctival injection, but still because it's steroid, we actually measure the pressure properly in every case, and it settled down after giving anti-glaucoma medicines. And these are some of the other cases where we got good results in our series. So all the questions that we set out with to answer, we could answer with our series that we were studying, that it can be used in active and inactive cases. 1 to 4 injections might be required. It has a long-term effect. Basically, it is stable, and more than 6 months we had seen, and there was no regression. There was no local side effect, no ocular side effects, and in both functional and cosmetic cases, this can be used. A handful of case series exist, none from our country. So this is the study from our country, wherein we have studied in 22 eyes of 22 patients and 37 eyes. And the mechanisms that have been proposed that I dug into in the literature has been either anti-inflammatory effect, but this actually is more true for when the active disease is going on, because that is when actual inflammation is going on. And second thing can be aponeurotic detachment or thinning of the muscles. So I would like to conclude that we have many things in the arsenal to treat these patients. It is very challenging. So keeping this injection in hand gives us an opportunity to kind of like treat these patients adequately, even when the active or the inactive disease is going on. These are my references. Thank you so much.
Thank you, Dr. Shefali, for the excellent presentation. Just one question. What is the technique of injection? How did you inject it?
So we evert the lid on the DEMARS in the OPD setup itself, and it's subconjunctival. It's not intralevator, but it kind of like just goes subconjunctivally
like
and
a Botox
sits over.
Injection?
No, sir. It's a triamcinolone acetonide.
Like a Botox?
Like
just
a Botox,
evert
yes,
it
sir.
and just
Yes.
subconjunctival?
Yes,
What
yes.
is the dose?
So dose according to the retraction that we got, but generally we kind of give either 1 ml, that is 20 milligram per milliliter of TA, or we can even go 0.5 to 1 ml.
Do you have any location? Do you give it laterally to decrease the lateral flare, or do you give it
So
centrally?
generally what we do is like go inside to the medial extent of the lid and kind of like withdraw the needle as and when we are giving the injection, and kind of it diffusely sits inside the
Did you monitor the
subconjunctival.
intraocular pressure? For how long did you monitor IOP?
IOP, sir, every visit, sir. Every visit
For
we
how
do.
long?
So till anyways, as a general routine also
2 or
we
3
measure
months?
yes, sir, yes.
And there was no IOP spike at
No
all?
IOP, sir. It's not like the intraorbital injections that they seem to have more increase in the IOP. This is subconjunctival. There's no leakage that we see. Even if there's a leakage, we kind of like put a bud and don't allow it to go to the
And
ocular
they were
surface.
getting parallelly IVMP also, is it?
In active cases, sir.
In active
cases, we start off with the IVMP, and after 3 cycles, when we know that it is not settling down because of the retraction and all is not responding to the IVMP, then we give after the 3rd cycle. 3 weekly cycles
And
we
if you
give.
want
That is
to
our
re-inject,
dose.
when did you re-inject? How many weeks later?
Sorry, sir.
If you want to re-inject, give a second dose of...
So 3 weekly the patients are coming, but we generally re-inject after 6 weeks.
6
But
weeks.
if we see that the depot of the drug is already there, we kind of like can see that yellowish sheen from the skin surface, we can delay it also. So ideally 6 to 8 weeks.
Thank you so much. Thank
Yes.
you. So I think with this we come to the end of this session. I'd like to thank the Chairman Anirban. I'd like to thank co-moderator Chandra and Dr. Aniruddha also. Thank you so much, and we'll hand over the session to the next chair. Thank you.
Can we have photo with all presenters? Please. Thank you.